5, 4, 3, 2, 1. We are live.
Okay, thank you. Good evening, all. Today we are on the session 3 of our exam booster series. This is a VR Spine Learnings initiative where we are trying to give opportunity to all the exam going spine fellows and also some of the PGs to attend the spine case presentations. We had 2 sessions earlier, two long case presentations. One of them was cervical myelopathy and the next was adolescent idiopathic scoliosis case, the last session. Today we have an eminent faculty with us, Dr. Samir Dalvie. He's a senior most spine consultant in Mumbai. He's from PD Hinduja Hospital, a very well-known figure in academic circles as well as an excellent surgeon. We're supposed to, Dr. Gururaj is supposed to join in some time. Hopefully he'll be free after his surgery. He is in ISIC New Delhi. And today we'll be having Priyank Patel. He'll be taking a lecture on scoliosis. He's taking a case presentation. Today we are Alok Gupta from Sanchet is going to present a short case on ankylosing spondylitis and deformity. And me and Dr. Nene will be moderating the session. Alok, you can load your PPT, please. And I'll give a brief until he loads the PPT. Dr. Samir sir and Abhay sir will start asking questions to him, and it will be a proper exam kind of a presentation where there'll be examiners and sir, you can actually stop him at any time and ask questions, sir. We have around 70 to 90 minutes for this case.
Sir, can you see my PPT, sir?
Yeah.
Am I clearly audible?
Yes, we can hear you. Go ahead.
Good evening, respected consultant, sir. Myself, Dr. Alok Gupta. I am presenting a case today. Shall I start, sir?
Yes, please.
A 27-year male, shopkeeper by occupation, resident of Odisha, presented with chief complaints of pain over the mid-back and lower back region since last 8 to 9 years. Progressive difficulty in walking with feeling of tiredness since last 1.5 to 2 years. Unable to sleep in supine position since last 1.5 to 2 years. There is a recent history of pain aggravated over last 2 months.
Okay.
History of present illness.
Carry on.
Patient, just a minute. Yes. Patient was apparently asymptomatic 9 years back when he developed pain over the right buttock, relating to anterior aspect of right thigh. Pain was dull aching type, insidious in onset, associated with morning stiffness, and improved with activity. Patient took medication from the local doctor, which relieved the pain to some extent. However, patient experiences the pain again as he stops the medication. For a period of next 6 to 7 months, patient also experienced pain in the left buttock, mid-back, and lower back. However, this time pain was sharp in nature and associated with morning stiffness and improved with activity. Patient continued to consult local doctors around his village and continued taking local medication. Initially, medicines relieve the pain. However, slowly over time, the above pain becomes persistent and there are episodes of exacerbation. Of around 4 to 5 episodes per year. As per the attendant, patient is walking with abnormal posture since last 1.5 years. Patient feels that his walking speed has slowed down now and he gets tired easily on walking for only half kilometer. And this difficulty in walking has progressed over the last 1 to 1.5 years. There is recent history of slight exacerbation of back pain over last 2 months. Pain has become sharp in nature and aggravates on movement. However, there is no history of associated trauma. Activity of daily livings are affected due to pain and limited mobility. There is no history of fever, weight loss, anorexia. There is no history of any major trauma in the past. No history of any weakness, numbness, tingling in any of the upper or lower limbs. There is no history of bladder or bowel involvement. There is a history of right heel in the past. However, at present, patient does not have any such pain. There is no history of hip, knee, ankle, shoulder, or any other joint pain. There is no history of pain over the joints of hands and foot. There is no history of skin rashes. There is no history of photophobia or watery discharge from the eyes. There is no history of altered bowel habits or bleeding per rectum or melena. There is no history of similar complaints in any of the first degree relatives of the patient.
Alok?
Yeah, let him finish his history, then we'll just go back again. Let him finish the full history. I didn't stop him for the same reason. Then we'll just go back.
True, sir. Carry on, Alok.
There is no history of addiction. There is no history of diabetes mellitus, hypertension, or any other major chronic illness in the past apart from this illness patient is facing. Yes, sir. Can I summarize my history now?
Yeah,
it's already there. The slide is already there.
Yeah, a 27-year male with long-standing mid-back, lower back, and bilateral buttock inflammatory pain since last 9 years, most likely due to axial spondyloarthropathy with abnormal posture while walking, with recent slight aggravation of back pain over last 2 months.
Your history is over?
Yes, sir.
Okay. So what is your impression? I'm going to start here and then we'll go back. What is your impression at the end of your history?
Sir, as per the history given by the patient is suffering from inflammatory type of back pain. Initially, he was having starting from the buttock pain, maybe involvement of the palatal sacroiliac joint, and thereafter the lower back and thoracic spine. And he is giving the history of that the pain is associated with morning stiffness, and pain gets better with the activities. Initially, the pain was used to relieve with the activity, but over time the pain has become persistent. And
so what is your impression at the end of your
patient is suffering from some spondyloarthropathy, sir, as he is having inflammatory type of back pain.
Okay, now just go back to the first slide because we'll come back to this. Just go back to the first slide.
Yeah.
Okay. So the question is that what was his present? Like, why has he come to you as an orthopedic surgeon or a spine surgeon? He's come with backache. Like, what is his problem? Like, you said pain in the mid and lower back since the last 8 to 9 years, accepted. Difficulty in walking with feeling of tiredness. So how is that an orthopedic history? I mean, because you've agreed that it is what he says, but unable to sleep in supine position. So what does he say? I can't sleep.
Sir, the patient is having a deformity, but he doesn't
exactly. So that is where you have come. So the reason the patient has come to you is for spinal deformity, right? Why has the patient come to the doctor? I don't know this case at all, but I'm just assuming based on what you're saying.
Yes, sir.
That this patient has come to you for spinal deformity.
Yes, sir.
Right. He's not come for pain in the mid-back. He can go to a rheumatologist. Feeling of tiredness, he can go to a GP. Unable to sleep, he can go to a psychiatrist. So that's not what he's come to you for. He's come to you. So your first presentation. Now here in the exam, it is not 100% necessary that you have to tell the examiner what the patient has told you. You have to little tailor it. You can't like completely change it, but you have to little tailor it. See, to me, this is like a vague. Why this patient? If suppose this was the OPD, and you're presenting this patient to me like this, I'll tell him, send him away, give him Crocin and send him away. I wouldn't even look at this patient. So the patient may not come out and tell you exactly what it is that he's come for. Sometimes you need to get it out of it. And in an exam, you need to bring that out to the examiner. So what's this to me? Like I said, I don't know anything about this case, but I know the topic of the presentation. That's about it. So the others, please switch off your mics. Everybody else switch off your mics.
Yeah.
So the thing is that to me, I would say that a 27-year-old male presents with progressive deformity of the back since X number of years. This would be my first line because that is the crux of the matter. That's the presentation. So that even is your last line. When it comes to impression, your last line is that a spinal deformity associated with. So we go into that, right? We are still miles away from coming to that sentence. So that deformity word has not come anywhere except just now when I asked you. The last thing when I asked you is you told me deformity. That he probably has deformity, but he didn't complain of it. That doesn't matter. Especially in an exam, you have to get it out of his mouth if he's not saying it. Right? So that's one. So your first line should have been that chief complaint is progressive deformity of the spine. That is his chief complaint. You have only one chief complaint. You can't have like a bunch of chief complaints. His other complaints are pain over the middle, lower back, etc. Difficulty in walking, feeling of tiredness. I would not mention it even if the patient tells you, because it's like too vague. Like, what do you mean a feeling of tiredness? He's got vitamin D deficiency, or he's lazy. Like, you can't mention that in an exam. So once you say progressive difficulty in walking, then I would have to ask you, does he have, like, because you've not qualified it at all. So does he have neurogenic claudication? Does he have vascular claudication? Does he have dyspnea on exertion? Does he have a pulmonary or a cardiac issue? Like, what is it? If you're trying to say he's breathless, I can still understand that when he walks, he feels breathless, because somewhere that joins to your diagnosis. See, eventually you have to weave a story which comes, which you have to weave a story with pencils, colors, paints, and that story has to then become a painting which has to be painted in front of the examiner. That is the aim of your entire history and examination. So that is very important. So I would not say feeling of tiredness. It'll irritate. Like, so suppose there's an examiner like me who gets easily irritated. I'll just get irritated with that, and then I just take you for a ride. Which is not what you want. In an exam, you want to be precise. Unable to sleep in the supine position is fine. So you can say that as a result of the deformity, he's unable to lie flat in bed. So that is fine. Because, like, if you are telling me that you're saying only what the patient said, the patient couldn't have used the word supine. Are you understanding? So just as he wouldn't have used the word deformity, he wouldn't have used the word supine. So you would have said that I can't sleep on my back. Okay? And recent history of pain aggravated over the last 2 months. We'll come to that. I'll just put a pin in that. We'll come to what that means. Okay, let's go to the next page. Okay, patient was apparently asymptomatic 9 years back when he had pain with the right buttock and anti-aspirate of the right side. What does this mean? So it started with a right buttock pain, which radiates to the anterior aspect of the right thigh. What pain is that? What pain radiates to the anterior aspect of the thigh?
Sacroiliac joint pain, sir.
How? Why is that? Why should that be your first guess? To me, the anterior aspect of the thigh could be a hip issue. Anterior aspect of the thigh, the hip issue is the first issue. The second is an L3 nerve root, right? So sacroiliac to the anterior doesn't come only. Like, so I'm not even sure how that comes, because sacroiliac will radiate posteriorly. So again, that history is like a little red herring. Even if he's given it to you, you should not say it. You should, because at some point, if it's you have to make it a little consistent for the examiners as well, right? So I would not say anterior, because like I said, anterior can be hip pain is the first diagnosis. I know it's a ASSI spine exam, but that doesn't mean the patient has just come to you. So you can say that. Okay. The other thing is, if I don't know whether you need to put this slide up in an exam, but if somebody is sort of a grammar Nazi like me, then there is no such thing as apparently asymptomatic. He was either asymptomatic or he was apparently all right. He's asymptomatic. Why should it be apparently asymptomatic? He's asymptomatic.
Yeah.
Or he was apparently all right. So apparently asymptomatic is wrong, but I'm just being nitpicking. So you can just ignore that. Coming ahead, pain was dull aching type, insidious in onset, associated with morning stiffness and improved with activity. So this is a very important thing. So what do you mean by morning stiffness, and what does that lead you to?
Morning stiffness is associated with inflammatory type of pain, sir.
Okay. Now again I've got you. Because in all of this, you have not really mentioned something, and in the end you've suddenly said inflammatory back pain. Okay. What is the crux of the matter of inflammatory back pain? What is the crux of the matter? Inflammatory back pain. What is the definition of inflammatory back pain? Like, what do you mean by inflammatory back pain?
The pain which improves with activity and aggravates with rest.
Aggravates?
With inactivity or rest.
Okay, so let's just put a pin in that and keep it aside, because that is wrong. What is non-inflammatory back pain? What is the other back pain?
Sir, mechanical back pain.
Mechanical. So you have mechanical back pain and you have inflammatory back pain. What is the crux of the two?
In mechanical back pain, the pain which aggravates on physiological loading.
The pain which worsens with activity is mechanical pain. It's a mechanical pain. So a pain which is aggravated by activity, or pain which is aggravated by movement. And the second part is also important. What is the second part? It's aggravated by activity and
relieved by rest.
Relieved by rest. So that's where you are. So what is an inflammatory back pain? An inflammatory back pain is the exact opposite. An inflammatory back pain will be aggravated by activity because there will be a mechanical component to it. But an inflammatory back pain is a back pain or a pain which is present even at rest. So that's an inflammatory back pain. So that is the major crux of the difference between those two.
Also, sorry to butt in, Alok, there are specific criteria defined in McNabb and other books which actually tell you the definition to call a back pain an inflammatory back pain. So you'll have to know those criteria. It's the duration of time that the pain lasts in the morning, etc.
So that is another level. So that's the next level of knowledge, that when you're diagnosing a SNSA, which is a seronegative spondyloarthropathy or an ankylosing spondylitis, then one of the diagnostic criteria for them is inflammatory back pain. That inflammatory back pain has a definition. That inflammatory back pain lasting for more than 6 weeks, the morning episode lasting for more than 3 months. 3 months. And each episode lasting for more than half an hour, right? So that is the correct. So that comes as a criteria when you're coming to a diagnostic criteria of ankylosing spondylitis. But right now, at this point, your very basic use of the word inflammatory back pain, which you used only in your last slide, for which there has been no justification in your history, is a problem, right? So whatever you say in an exam, you have to justify by whatever you said before. You understand? Whenever you conclude anything, you have to justify it by what you have said before. So that is very important. So now morning stiffness is like, you need to know the criteria to diagnose morning stiffness as being part, but because you can get morning stiffness even in rheumatoid arthritis, right? So you can get in that as well. So that is important. Patient took medication from local doctor, which took things. So that's a little vague of a little vague history. But if you get some history, I don't know, I'm not 100% sure, that improved with non-steroidal anti-inflammatory drugs, that may be a good history to give, provided it is precise enough to be reproduced. Like, I mean, I can understand the issue there sometimes, that the examiner may suddenly ask the patient and the patient doesn't know, right? So this anterior thing, maybe it was posterior. Now the patient isn't here, so we can't really ask. Maybe it was anterior pain because maybe he was getting a hip inflammation, for all you know. It may have started with the hip synovitis. We don't know what happened 7 years ago. But sacroiliac joint is not anterior. That you need to be sure of, right? Coming to the third point, over the period next, I was experiencing pain in the left buttock, mid back, and lower back. This time the pain was sharp in nature, the morning stiffness improved with activity. In this, if you can say that these movements, this pain restricted his movements or restricted his bending, he found difficulty in bending and restricted. If you can get it out of the patient and put in history, that's a very good point to, because see, by just looking at the patient, you know his ankylosing spondylitis. So it's not a mystery. You don't need a CT, you don't need an MRI. This is not like a swelling on the humerus, which you're already saying osteosarcoma because you know the case. No. Ankylosing spondylitis is a blind guy can tell you. The minute he walks in front of you, you can see it. So if you can add that as well, restriction in movement, that will give you like a big picture, because what you're getting now is, till now in 2 slides, you're painting a picture of a male, very important, in the second decade, very important, with back pain starting in the low back, axial pain, restricted to the back, giving rise to morning stiffness and restricting his movement and getting a deformity. So you are painting a picture. That's what I meant. You're painting a picture for the examiner. Samjha? Okay. Are you with me, guys? All of you. I think there are like many people washed up, right? Not washed up. Lockdown. Okay. We'll just go to the next slide. As per walking with abnormal posture. So this rather than walking with abnormal posture, you can either say his gait altered or he is going in for a spinal deformity. I think I should say that. For the last 1.5 years, he was walking. His speed has slowed down and he gets tired easily on walking. So this you need to again specify. This tired, whether it's claudication, that he gets numbness and heaviness in the legs and he has to sit down, whether if you want to go down that path at all, because then they will take you down the path of lumbar canal stenosis, right? Or whether you want to say that he gets breathless, which is quite okay again, because that fits in with your diagnosis.
Yeah.
Okay. There is recent history of slight aggravation. So here you should be precise that whether he's got severe pain, because you're saying slight aggravation and then you're saying sharp in nature. So is it slight or is it sharp? They are both, because both of them mean hugely different things. Like assuming that we already know the diagnosis, what does a slight aggravation mean? A slight aggravation could mean what?
Alok?
Yes.
Yeah.
Alok, don't get nervous. Today I'm at my lowest peak. I'm just gunning at 10% my normal.
Yeah.
So
okay, let us say
pain,
there is slight. See, there are two things. Right? We know already that we are going in the direction of SNSA, seronegative spondylotrophy. We already know we are going in that direction because you have seen the patient. Although it's a history, but the patient is in front of you. Also, the way the history you built up the picture now is still that. In this scenario, in the background of ankylosing spondylitis scenario, you have two scenarios. One is there's a slight increase in pain, and one is there's a sharp increase in pain. To your mind, what is the first thing which comes to if there's a sharp increase in pain? Let me just put it. Like, why would you have a sharp increase in pain?
Any fracture can result in sharp increase in pain.
Oh, so a fracture and a slight increase in pain?
Any, just the inflammatory activity has increased.
Exactly. So it can be because it's a waxing and waning thing. So it may be that there's an inflammation is going on. So he's got an increase in pain. Or some other joints are affected now. That's why. Okay. Activities of daily living are affected due to pain and limited mobility. Next.
Yeah.
So there is one more thing. You just said fracture. You said fracture, but you're saying there is no history of associated trauma. Can he still have a fracture?
Yes, sir. If Anderson lesion is considered as that in the mind.
Exactly. That's what we are trying to get out of you, like a pseudo fracture or an Anderson lesion type of injury. Okay. Next slide. Okay. I think this slide is any of the exam. Priyank is there or not there?
Yeah, I can see. Yeah.
Good evening, sir. Just joined us.
Hi. Priyank, you just joined?
Yeah, just joined.
Oh, okay. Sorry. So, we are just on the first few pages of the history. So far, we have got a 27-year-old male with inflammatory back pain for 8 to 9 years, deformity since 1.5 years, and increased pain in the back since the last 1.5 years. We are just going through the negative history pages. It interferes with the activities of daily living, and his main issue is deformity is one of the issues, and the second issue is this increased pain in the last 2 months.
Okay.
Right. So we are now on the negative history sort of thing. So this page we are also. This page is fair enough. Now we are going.
Yeah.
So by the way, in negative history, why should there be history of right hip? That's a positive history. But anyway.
Yeah.
So does heel pain fit in with your diagnosis?
Yes, sir. It fits because enthesitis.
Okay, good. What is enthesitis?
So the inflammation of the attachment of the tendons or ligament or bony capsule to the bone.
Correct. So enthesitis or enthesopathy. It's known as enthesopathy, and enthesopathy is one of the hallmarks of SNSA. Right. So even the spine, the problem is actually an enthesopathy everywhere. Okay. No history of hip, knee, ankle, shoulder, or elbow pain is not a very good history because, but if it is because hip, all of these joints can be involved. But if it isn't, it isn't. Like, that's fine. No history of pain on, I would say, small joints, because when you say small joints, it shows me that you're thinking of
rheumatoid arthritis. Rheumatoid arthritis.
So it's just a usage of a few words which, for the examiner to feel, isko aata hai. You just need to sneak in those few keywords to let the examiner think that this guy has read it, right? No history of skin rash. What is the significance of that history?
So one of the criteria is psoriasis, sir, in his ASS.
Okay. One of the criteria, or what is it? No, that is not exact. Your answer is not wrong, but your answer is not 100% right. A clarity of thought. So just tell me again, like why are you looking at skin rashes?
There can be associated psoriasis, or patient can have psoriasis, or it has presented with axial spondylorthopathy.
Exactly. So it is not that patient can have psoriasis. See, ankylosing spondylitis is one particular disorder. That's ankylosing spondylitis. SNSA is a group of disorders. That is seronegative spondyloarthropathies. Ankylosing spondylitis is one of the seronegative arthropathies, but there are other seronegative arthropathies which are, one of them is known as psoriatic arthropathy. The other one is your next two questions. What are they? Second one, photophobia, water discharge. What are you looking at?
Sir, anterior uveitis, sir.
Uveitis. Okay. So uveitis is okay. Uveitis is associated with SNSA. That's fine. Next one.
Sir, I'm looking with altered bowel habits and bleeding for rectum and melena for inflammatory bowel disease like ulcerative colitis or Crohn's disease.
Right. So Crohn's. So what happens is that, again, this is different. It is not ankylosing spondylitis. It is a arthropathy associated with IBD, inflammatory bowel disease. Okay. And what is Ritter's syndrome?
Yes, sir. Ritter's syndrome. In Ritter's syndrome, there occurs sometimes monoarthritis or oligoarthritis associated with pustules or vesicles formation over the pantopalmar surface with
Ritter's. It is a gonococcal urethritis, which also is associated with
the gonococcal Clybacter trachomatis and Shigella infection. It can result in Ritter's disease, Ritter's syndrome,
which can also cause a SNSA, seronegative spondylitis. Yeah. So again, no history of complaints in first degree. Fine. There is some kind of genetic history backup. Next. Short history. Okay. So this is the interesting one. So 27-year-old male with long-standing mid. Yes. Sorry. You had a question, Harshad?
No, sir. No, sir. No.
Okay. Somebody had a question? Or any? Even I think the other students are allowed to ask questions. I don't know.
No, they can ask doubts if they have.
They can ask. They are, but I don't know whether I know the answers or not. It's easy to be an examiner. It's difficult to be a student. So 27-year-old male with long. So guys, if you have questions, you can ask, or I don't know whether there is that finger up thing or there's writing. Chat pe kuch kar sakte ho.
Yeah, chat is there.
Yeah. So in chat there's a question. What was the Anderson? Yeah.
And it's an ortho guy.
Okay. Okay, so this is the TV people. Okay.
Yeah.
So long-standing mid-back pain or actually with abnormal posture while walking. So I would still say you need to start with deformity, because it's a deformity. See, now I have not seen the patient, so I don't know, but you've seen the patient, and in the exam the patient will be there if I'm not mistaken. So you can see that the patient has deformity, right? He's come to you for deformity. So so I would say that it's a 27-year-old male with progressive spinal deformity. Okay. Associated with an inflammatory, non-mechanical kind of back pain and reduced activities of daily living. With this slight aggravation, there's something you need to know. We need to know one way or the other. You can't be fudgy on this. So when the imaging comes up, then we'll also know. So till such, and if the patient was there, we would also ask him. So you need to be one way or the other. Is it slight aggravation or is it a sharp? So that's one more thing which you need to know. And what is a transitional pain, by the way? Transitional pain.
Alok?
Translation. Hello.
Transitional pain. Transitional.
I don't know.
It's okay. Everybody.
Instability pain, you want to know?
Yeah, instability pain is like while turning in bed, the patient is having the pain, or while getting up from the sitting position from supine to sitting or sitting to standing. The patient experiences the pain, then it's instability pain.
So when I'm looking for transitional pain, I am looking at pain in change of position. So what happens is that when a patient is lying down, like from sitting to lying down, he gets severe pain. And then sometimes that pain settles, and he won't have pain even if he sleeps for however long. When he gets up from lying to sitting, again he gets severe pain. That pain will last 5, 10, 15, 20, 25 minutes. After that, again, there's no pain. They can do the whole day without pain and come back. This transitional pain is very typical of a few things. Not in this case, but otherwise, it is typical of a non-union osteoporotic fracture. And it is also typical of a Anderson lesion. Because what happens here, as well as what happens in the osteoporotic fracture business, is that when the guy lies down, the Anderson lesion opens out, because there's a little instability over there in that deformity, or in your osteoporotic fracture center, it opens out. So there's severe pain while it's opening out. Then it goes to a position of stability. Then the patient is completely okay. When he gets up again, that whatever is opened out again load. So axial loading ke karan it closes again. So again he'll get a deformity. That during the time there'll be severe pain. Once it settles, once it's on the other, then there's no pain. So I know patients of ankylosing Anderson lesion who don't sleep only. They sleep seated only, where they just can't lie down. They remain seated. They're happy. They'll get up once. They'll be whole day. Maybe at night they'll try to sleep once, but some of them don't sleep for days. They just remain seated. So this is what at least we call transitional pain. The nomenclature may not be precise, but at least this type of history you should know that it's an important part of history. So this is your last slide in history, right?
Yes, sir.
So now you know. So now remember, in an exam, whether it's any exam, medicine, surgery, gynac, but especially in orthopedics and in our case spine, at the end of the history, you should be able to tell what it is, right? And at the end of your examination, you should be able to tell where it is. Are you getting? That is a very, just boiling, taking the crux of the thing, what it is at the end of your history and where it is at the end of your examination. So I want to know, what is your impression? The summary you have given. What is your impression? What does this patient have?
This patient is having progressive deformity of the back, due to which he is having difficulty in activities of daily living.
No. That is diagnosis. That is different. Yeah. I want to know what it is. That is your diagnosis. Your diagnosis is this: 27-year-old male with progressive spinal deformity with this. Due to what? Like, what is your impression at the end of it?
Patient is having axial spondylopathy, there is progressive deformity due to ankylosing of the spine.
Oh, no. So let us go back. Let's make it simpler, because you are getting, you think I'm asking too difficult a question. I'm actually asking too simple a question. So the answer is that this patient has spondyloarthropathy with progressive spinal deformity. And this Anderson lesion hai ki nahi, I don't know, because your history is not clear. If he has, then you need to say it. And if he doesn't have, then you need to say he doesn't have. Or then you don't need to say, you just need to keep quiet, right? Then my next question to you is, why do you say it is ankylosing spondylosis? Why do you say? And then they give you the chance to answer all these questions. That he is a male in the 3rd decade who has been having long-standing history of axial back pain, which started in the low back and is progressing upward to the dorsal spine, and he's getting a progressive deformity. So this is very likely to be a spondyloarthropathy. So this way I know that you know, like you like I said, you paint a picture. The picture is complete now. There is nothing which is left empty for me to search into it. Okay? The dyspnea on exertion and all also is a good thing, because it can help you. But I mean, if it's there, it's there. If it's not there, it's not there. Bolo, any of the other examiners, any question?
Yeah, Priyanka, you want to add something? Yeah, so we'll carry on.
Okay.
Yeah.
General examination. Patient is conscious and well-oriented, time, place, and person. Nutrition is good. Patient is afebrile. Pulse 74 per minute. BP 120 by 80 in the right upper limb in supine position. Respiratory is 16 per minute. No pallor, icterus, clubbing edema or adenopathy. Estimated examination is CVS examination is normal. There is no murmur heard. Respiratory examination, chest expansion was decreased. There is abdominothoracic pattern of breathing. And per abdomen was soft and non-tender.
How did you check for chest expansion? Unfortunately, there's no patient over there. But how do you check for chest expansion?
Chest expansion is checked at the fourth intercostal rib. We ask the patient to take to exhale completely and then take a deep breath. The chest should expand more than 2.5 centimeter for considered as normal.
Okay. So I think the criteria for this restriction is 1.5, if I'm not mistaken. So more than 2.5 must be normal, more than 1.5 must be, as far as I remember, and I may be wrong. So if somebody has read it, then they should know. Okay. And why is the chest expansion decreased?
Because there occurs fusion of the costovertebral joints.
Fusion of the
costovertebral joints.
Okay.
So the expansion of chest decreases.
Good. So again, a short answer can be emphysiopathy of costovertebral costotransverse joints. Next.
Because there is this bucket handle movement. You have
Yeah.
to go deeper into it. There's a bucket handle movement of the ribs when you inhale and exhale. So that movement is blocked. So because the bucket handle isn't there, the ribs which are vertical can't become horizontal. When the ribs which are vertical can't become horizontal, the sternum can't come in front. So your chest expansion is reduced. Okay. Next. For abdomen socket tendon.
So can I show the gait?
Yeah.
Please show your presentation.
Patient is walking with slight downward-looking gaze with shorter stride lengths. Bilateral upper limbs are hanging behind the body throughout the gait cycle. Bilateral knees are flexed throughout the gait cycle.
Okay. Why is he flexed his knees? Why is his knees flexed? He has a flexion deformity of the knee.
No, sir. This is not a flexion deformity of the knee. This is a compensatory mechanism to bring the sagittal vertebral axis back. Sagittal vertebral axis over the center of the gravity over the pelvis.
Okay. Go ahead.
Inspection. Patient is standing with arms hanging behind the body with hip extension and knee flexion. There is rounded curvature of the thoracolumbar spine with loss of lumbar lordosis. Head is slightly, inspection from front, head is slightly on right side as compared to the pelvis. Left shoulder is higher as compared to right shoulder. Umbilicus is centrally placed. Right ASIS is higher as compared to left ASIS. Inspection from back. Head is situated slightly on the right side on pelvis as trunk is tilted on the right side. The curvature of spine persisted in the sitting position. This curvature of the spine persisted in the sitting position. Hairline level is normal. Left shoulder is higher as compared to right shoulder. Center furrow is obliterated. Right PSI is higher as compared to left posterior superior leg spine. Bilateral gluteus muscle appears to be wasted. There is flexion at both the knees and there is no tuft of hair, scar, sinuses or dilated veins over the back.
One sec, sorry. Can you
come back? Yeah.
Sorry, these images are not the correct images.
It's okay. Doesn't matter. So the curvature of the spine persists in the sitting position. What does that imply?
There is slight shift of the trunk on the right side. Or there is a curvature.
No. The curvature of the spine persists in the sitting position. What is the implication of that? Like, why would it? In what condition would it not persist?
When it is coming from the pelvis or infrapelvic pause, then it will disappear.
Okay. Any other reason why it would? If it's a compensatory deformity, right?
Yes.
If it's a compensatory deformity, then it would disappear. If you have either because of root compression or because suppose it's like because of neurogenic claudication. If the patient has gone into a stoop because of neurogenic claudication, when he sits, that it'll be a correctable deformity. What hairline level is normal is for what? What are you ruling out?
Klinefelter syndrome.
Which one? Which one?
Klinefelter syndrome. Maybe.
No. Something else. Klippel fail.
Klippel
fail. It's okay. No problem. Left shoulder is higher compared to the right. Central furrow is obliterated.
So what? Okay. What does this signify? The left shoulder, the right PSIS, and everything. Why have you? I mean, what do you get from it?
There is a curvature. There is a curvature present with convexity towards the right side, and with the right shoulder higher, and left same side SIS lower. So we have to rule out the. But this curvature is persisting in the sitting position. So mostly this is coming from the spine, and we have to confirm this finding in the examination, further palpation and other things.
You're suspecting a coronal plane deformity also?
Yes, sir.
Okay. Carry on.
Okay, carry on.
Both superficial and deep tenderness present over the spinous processes in the thoracolumbar spine. Bilateral sacroiliac joint tenderness present. Paraspinal muscle spasm is absent. Local temperature is normal. It is rounded curvature palpable over the thoracic spine in the sagittal plane at the thoracolumbar spine. While there is a shift of the spinous processes tips on distal to proximal palpation towards the right side in coronal plane. G7 plumb line falls on the right side of the natal cleft.
Okay.
How did you see? Because this patient can't stand straight. How did you do his plumb line? And by the way, the plumb line is not from C7. It's from the occiput. But if this patient can't stand straight, because this plumb line is for coronal deformity, right? If he's bent like this, how did you even do the plumb line? It won't even hang. Anyway, okay, go ahead.
Movements of the cervical spine are slightly restricted. Movements of the dorsal spine, chest expansion around 1.5 centimeter. Finger floor distance is around 25 centimeter. Modified Schober chest is positive. It's coming around 3 centimeter. There is restricted extension, lateral flexion, and rotation of the thoracolumbar spine.
No, wait. Sorry, this is the main one. So, what do you mean by extension is restricted? In what way?
I was not able to do. I asked the patient to do that movement, but the pelvis was moving on that movement.
So basically, restriction is extension is absent. He's flexed. He cannot extend only.
Yes.
He's got a fixed flexion, right?
Yes.
So you say extension is absent. He cannot come to even neutral. Okay. Tell me about the Schober's test. What is Schober's test? What is modified Schober test? What is modified Schober's test? Some little theory, tell us.
In Schober's test, we mark both the PSIS, right and left, and then we take a 10 centimeter tape, and then
Hello, come on. So
yes,
don't get flustered. Simple question, simple answer. Why Schober's test is done, how it is done, and what are your interpretations of Schober's test? Go one by one. What is it done for?
For checking the flexibility of the thoracolumbar spine or the lumbar spine.
Is it thorac?
Lumbar spine.
Lumbar spine. Okay.
Yeah. Now, what is the procedure? How do you do it?
In modified Schober's test, we take the 50 centimeter each tape. 10 centimeter we keep above the line joining the PSIS level, and 5 centimeter below it.
Okay.
And then from PSIS to the 10 centimeter above point, this point should go more than 5 centimeter away on bending forward, or consider the test to be normal.
Okay. What is the difference between Schober's test and modified Schober's test? What sir asked.
I don't know.
And why it was modified?
I don't know.
Okay. So this you need to little read. Okay.
Yes, sir.
And there are little different things, because the Schober's tests actually are described by rheumatologists rather than orthopedic surgeons, right?
In fact, sir, can I add?
Basically, there was some,
That same thing about Schober's test. The concept is the same, except in Schober's test, they want to pinpoint and mark the L5 vertebrae. So the spinous process of L5, that discrepancy that is there, clinically identifying the lumbosacral junction. To remove that, they used PSIS. So initially in Schober's test, it's the L5 lumbosacral junction or L5 spinous process and 10 centimeter above it, and then ask them to forward bend. And to remove that discrepancy, the orthopods came up with this modified Schober's test where they are using PSIS, which is more easily identifiable.
Yes, but then there is a modified one where there is also 5 centimeter below to look for lumbosacral junction movement. So the first Schober's test was L1 to L5. Okay, where that L5 was not identified properly, or there was inconsistency in being identified. After that, it came where it was identified by this transverse line between the PSIs. That was the modified Schober's test, and then the modified they took even 5 centimeter below and 10 centimeter above, and then they looked for the excursion. Okay.
Yeah.
Bolo. Next. So what does it identify? I mean, basically lumbar flexion. So in this patient who's got a clear-cut ankylosing spondylitis, it is important just to complete your history and your examination and all of that. But in your OPD for other patients who just walk in with backache, it's very important to do that, because you can have a patient who can touch his toes, right? But his lumbar spine excursion is bad. So you have to do the Schober's test on your OPD patients also, right? So you have to just like roughly put your finger and just see whether it's getting taken. Next.
And Alok, you should also mention if the restricted movement is painless or painful. Painfully restricted versus painless.
Yes, sir.
Yeah, go ahead.
There is apparent lengthening of around 1.5 centimeter in the left lower limb. Two limb lengths and segmental lengths are equal bilaterally. I was confused over this point. I should not mention like this, but I was not able to square the pelvis. Pelvis was like ASIS on left side was down and it was not moving at all.
Okay, tell your interpretations about that.
Because this is going to be a little. Because see, with a fixed spine, I'm not sure whether you can
do these measurements.
Even true lengths are not able to,
because you can't because see, to get this, you need to square the
pelvis.
Yes. You should be able to square the pelvis, no? So which you can't square.
So Alok, if you go back one slide, the second point that you mentioned, there's apparent lengthening, which you can say, but you can just mention about the segmental length. You can't talk about true limb length because you are not able to square the pelvis. You just say that you're not able to do the true measurement because you can't, and you've just segmentally measured the tibia and femur.
Yes, sir. Test for sacroiliac joint, Faber's test, pelvic dissection test, and Gensler test are positive. Again, I want to mention here that the patient cannot lie supine completely. So these tests were done after elevating the bed and after elevating the head side of the bed and making patient comfortable. SLR test cannot be done as patient cannot lie in the supine position. Examination of bilateral hip joint and bilateral knee joint was normal.
So my only question is that, of course, this patient isn't here. But these usually, by the time the deformity sets in, these tests are not positive.
Correct. Added same question. Added same question that I was always confused about this test, that whether in a case of deformity, whether you should talk about these tests. Yeah, because at this time SI joint is completely fused.
So this would be like for a active spondyloarthropathy, or a sacroiliitis. So I'm not sure. So you have to know these tests, because in an exam, especially if you have a North and South examiner, they will ask you to demonstrate these tests. If you have a physical exam, if you have a virtual exam, then not. And these are the few tests. They have physical. So then these tests you will have to be demonstrated. So even if you have a case of LCS, you will need to know how to do these tests. So you should know all the SI joint tests and you should be able to demonstrate all of them properly. So now, of course, there's no question of that. But I'm just saying that in principle, I'm not sure whether they'll be positive in this patient.
Correct. Yeah. And the other thing is that you just mentioned in the previous slide that you're not able to square the pelvis. There's a fixed flexion deformity, and then you're mentioning that the bilateral hip examinations is normal. So when you're writing your history, you have to make sure that you are writing it correctly, because obviously it's not going to be normal over here.
So actually, don't blindly follow the protocol. Just think over it, what you're doing. And now, even in radiology, when X-ray comes up and you have a completely fused joint, and then how did you do a SI joint test and everything that will come up? So better be sensible about what you're talking.
So the hip also won't be normal. So
Yeah.
there will be a flexion deformity or something of that sort. No, hip rotations are normal. I can understand that in your mind you're looking at hip rotations. So hip rotations may be normal, but not. And most of them have some protrusion also. Even the rotations are very rarely normal. Very rarely are the hips normal. The hips may be mobile, and that's a different question. That comes to when we come to the surgery part of it. But okay, go ahead.
Yeah.
Neurological examination.
Okay, this you just go ahead. This you go ahead, because we won't have time to talk about ankylosing.
Yes.
Mostly the neurological examination is normal.
So this is in a PID case or other case, we'll talk about this. Not right now. Neurological is okay.
Yeah.
So you've not done one very important thing. The most important thing in this is the chin brow vertex angle. That's why I was waiting for you to come to that, because the other things don't matter. What matters in this patient, there are few things which you need to look at. One is the chin brow vertex angle. The other thing is the hip mobility. And the other thing is the mobility of the cervical spine. So these are the three important factors which are there for when you plan the management of this patient. Right. The other question is that your tenderness thing also was very vague. You said superficial and deep tenderness over the entire spine, where actually they don't have. Ankylosing spondylitis patients never have. So if at all you're gunning for Anderson lesion as being part of the thing, then there will be specific tenderness at that point, which will be a deep thump or a pushing tenderness. But an ankylosing spondylitis will not be tender over the entire spine, which is what you said, that superficial and deep tenderness is throughout. Okay. So these are a few things which you little missed out in the examination. That the deformity examination of an ankylosing spondylitis deformity, these few things need to come in, right? Okay.
Come on. Diagnosis.
27-year male with progressive kyphotic deformity of the thoracolumbar spine due to axial spondyloarthropathy with no neurodeficit, with activities of daily living affected due to pain and limited mobility.
See, again, this thing is very vague, because you have not like this again is vague. Has he come to you for pain? Has he come to you for limited mobility? Like, what has he come to you for? He has come to you for the deformity, right? Has he come for? I'm asking you. You've seen this patient or you have not seen the patient?
Yes, sir, I've seen.
You have seen the patient. So has he come to you for deformity or has he come to you for pain?
Deformity.
So deformity. So that should be your first thing. That he presenting with, right? So
he's added that on the first line. Yeah. That progressive kyphotic deformity of thoracolumbar spine. But he's added that caveat in the end, pain and limited mobility.
Yeah. Okay. And what is axial spondyloarthropathy? Spondyloarthropathy is axial. Spondylo means what? Spondylo means spine. Spondylo means spine, no? Yes. That's axial. Okay. So I'm not sure whether about the word progressive, because of course it has progressed because it has come to that point. But for you to call it progressive from this point, you have to follow up for another 6 months. So we don't know whether it's progressive or fixed. So he has presented with a kyphotic deformity. Right. So how would I put this diagnosis? 27-year-old male with spinal deformity or with kyphosis, presenting with kyphosis, most likely caused due to seronegative spondyloarthropathy. It is, most likely caused. You can say with the seronegative spondyloarthropathy, most likely ankylosing spondylitis with no neurological deficit. And this pain ka thing, like we need to figure it out, because like I say, you need to put your thing in one way or the other. You need to yes or no. Anderson hai ki nahi hai. You need to decide this, because in the exam you won't get the X-rays before that. So clinically you need to paint a picture this way or that way. right? So whether you're going to stick only to a deformity part of it, which is fair enough. Like if he doesn't have pain, he can have a deformity. You can still have an Anderson on an X-ray and an MRI, because all Anderson lesions are not necessarily painful. They may be there on the X-ray, MRI, but it may not be there. He may not have pain. So you leave the symptoms on one side. But if he has pain and point tenderness and transitional pain, then you can say he probably may have a pseudo fracture or an Anderson lesion. You cannot say it until you see the imaging, right? And if you say it without seeing the imaging, they'll say somebody's told you. Okay. Any other questions from any of the examiners or any of the students or Abhay or anybody else on the on the story so far, like history and examination?
Priyank, so you want to add something?
Oh, I think all covered.
Yeah.
Okay. So we are going to take a 1.5 minute break.
Yes, sir.
Is that
Yes,
okay?
sir.
I just refill my coffee. Otherwise,
Sir.
1.5 minutes only. So you all
Sure.
can continue the discussion. Continue discussion.
Yeah.
I just have to go to the other room and get my coffee.
So basically, whenever an angst case comes, it's always going to be, I mean, most probably it's going to be a short case. Commonly, it can come as a long case also. And depending upon that, you can modify your history of presenting illness and also negative history, because here negative history will be significant. History of associated symptoms, history of etiology, history of complications and everything. And then you should, whenever you're giving a history, a diagnosis at the end of history, each word you use should be justified by your history. What sir was telling, sir very nicely explained all the things, why you say progressive deformity and everything. And Alok, I would want to ask one more question to you. Pain, sharp pain, what are the differential diagnoses that comes to your mind in SNSA?
Sharp pain, firstly, it can be just the exacerbation of the inflammatory activity.
Okay. Second.
It can be due to the Anderson lesion.
Okay.
It can be due to the fracture.
Before Anderson, what happens? Discitis.
Discitis, rheumatic discitis.
Yeah. So all these things. And then, perfect. So sir has actually taken, he's presented his own version of it to you. So you know what specific words you should use. And whenever you're using any word, slight, mild, moderate, you should avoid using those words and be very precise about using your terminology. Yeah. Priyank,
We've not come to the images yet, right? It's
we're
just
coming.
an examination. No, till now we are just at history and exam. I was in and out. That's why I'm not sure.
Yeah.
So just history and examination.
We are not come to images.
In between, there was a discussion about the palpation of the spine.
Yeah.
Correct? So I just saw that bit. There are different styles of palpation of the spine. Are you aware about that?
Yes, sir.
What all do you palpate in the spine?
Sir, are you specifically asking about tenderness?
Yeah. So palpation, when you do that palpation bit, when you mentioned, there are 2-3 specific things if you know. Then so there is point tenderness, then there is thumping tenderness. There is also something called as rotatory tenderness. So these are 3 different types of tenderness that you have to try and elicit whenever you are dealing with the spine. The other thing is when you're doing about the movement, you should know the normal movements of the spine, the normal degrees, the rotations, and mention about that bit as to if it is painless, painful, and then the special tests, you should know about them. But like what Samir sir said, you have to be smart where to, like, you don't talk about like SLR is not very important in ankylosing spondylitis. So you have to guide the examiners in such a way that you are very specific and you want to immediately go to the main part, and that is the imaging and the management. Because if you get stuck in the examination bit, then you just get stuck there and you'll never be able to move ahead. Okay, cool. Sir is here. Let's progress.
Yeah, I'm here. So the most important question is now, what will you do?
So first, I would like to, I want to do the X-rays. I would like to do the whole spine standing X-ray, AP and lateral view, including pelvis, bilateral hips, and the femur.
Okay. So you want to do one X-ray, like a scanogram X-ray, is it?
Yes.
Okay. So tell me again, what X-ray are you going to do? AP? Tell me.
AP and lateral view, full spine. AP and lateral view, including bilateral hips and the femur.
Okay. And lateral as well.
Yeah. Alok, lateral also, right?
Yeah.
Yes, sir.
So, Alok, which X-ray is easy to take or which X-ray is maybe difficult to take? The other way around?
Among AP and lateral.
The olden days, it was a favorite question of examiners. We have now stitching and everything available. So typically in that film, the lateral film, because of the kyphosis and all, typically patient may not fit in an X-ray. Yeah.
Is there any instruction which you will give to the radiologist while taking the lateral X-ray? Or you just send them, you'll write lateral X-ray. Jao. Why were his knees flexed?
Knees were flexed because of the compensation. So
what is chin brow vertex angle?
We have to ask the patient to stand in hip and knee in neutral position so as to remove all this compensation, and then the two deformity manifest, and then we measure this chin brow angle.
Chin brow. So how do you measure it? Chin brow to?
From the like if the patient is facing like this, so from the vertical point, and then.
Right. So then how do you eliminate that that first thing, the knees are flexed? What do you tell them to do?
We ask them to keep the knee in the extended position and
go against the wall. Yeah, you make them go against the wall and extend the knee. Now, what instructions will you give to the X-ray person when taking the X-ray?
The same thing, he ask the patient to.
Exactly, So that is what I'm trying to tell you. So your how one point of knowledge has implications on various things. The fact that that because of this, the patient compensates. Why does he, by the way, flex the knee?
So as to bring the center of gravity over the hip axis.
Okay. So and then why do you extend the knee?
Just to remove this compensation, so that
when you remove the
deformity, we can estimate the true deformity.
So the instruction you will give to the X-ray technician is that you need to extend the knees when you are taking that. Okay. So this X-ray, we have decided on the X-ray as being the first investigation for you. You don't want to do any blood tests. Do you want to do HLA-B27?
If X-ray I can prove that there is sacroiliitis, then there is no need to do the HLA-B27.
You see sacroiliitis on the X-ray or on the MRI?
Sacroiliitis on the X-ray also.
You see sacroiliitis on the X-ray?
No, sacro.
Okay, let's put out the X-ray and see what we can see. Describe this X-ray.
First, I describe the AP X-ray. This is the standing AP X-ray. It is placed on the right side of the pelvis. There is a thoracic curve present with convexity towards the left side. Left shoulder is higher placed than the right shoulder. Vertebrae in the lumbar and the thoracic region appears to be fused.
I'm very sorry. I'm just going to jump back. I won't ask you. I'll just tell you. You forgot to say mouth opening. I suddenly remembered. You forgot to say mouth opening. That's very important in your history. Like right now, because it's post 9 o'clock, I'm a little sleepy myself. If this was a morning exam, I would have caught you on mouth opening. Okay. Anyway, sorry. Come back.
Vertebrae in the lumbar and thoracic region appears to be fused. Syndesmophytes. In the middle, there is fusion of the spinous process as well, with a characteristic dagger sign. And there is a characteristic bamboo spine appearance on the radiology. Left ASIS is lower than the right ASIS.
I would say I like I said, there are both ways of doing it. One is you can just describe. The other way of doing it, sometimes you can just say it. You can say this X-ray confirms my diagnosis of ankylosing spondylitis, and then you can start. So both are okay. It's like fine. You can start by just describing it and then asking the examiner ask you, so what do you think? Or you can say, because this one is a crystal clear one. There is no sort of two ways about it. Yeah, ambiguity. And what do you say about the sacroiliac joint in this patient?
So there appears to be completely fused.
So it doesn't have sacroiliitis, no? Doesn't have, no? Okay. In the lateral X-ray?
In the lateral X-ray, so just there is
Sorry, Alok, you said there is no sacroiliitis or the sacroiliac joint is affected?
I said there is sacroiliac joints are fused.
Okay, fine. I missed that part. Sorry.
In the lateral X-ray, there is a rounded curvature at the thoracolumbar spine, and there is a fusion of all the vertebrae at the lower lumbar and the thoracic junction. The pelvis appears to be retroverted, and there is the C7 plumb line. There's a global sagittal imbalance.
Yeah, we don't know whether this X-ray was taken with the knees touching the wall or not, so we don't know about that. But anyway,
more than that,
and the pelvis is not retroverted. The pelvis is not retroverted; it's antiverted. But anyway.
So, sir, we can use the word proper, na? Thoracic hyperkyphosis, rather than saying the global rounded deformity. As a fellow, it should be, yeah,
for sure.
Go ahead.
So, because if this X-ray was taken with the knees against the wall, it would have been much worse.
Much worse, yeah.
Okay, go ahead. Next, that other X-ray, hip X-ray there looks like the next one. Okay. So here, can you say about the sacroiliac joints?
Yeah, there appears to be fused.
Okay. Hips.
I have only
Hips
these. Hips are normal. Sir.
Little up. No, they're a little abnormal. They're a little abnormal. He has got a little protrusio. They have a little protrusio. Anyway, why is the hip mobility important? Why is it important for the hip to be mobile?
Hip can also contribute in compensation.
And for instance, suppose this patient, okay, we'll come to it later on. We'll come to it in the management part. Go ahead. Next. For any further investigation? X-rays are done. X-ray has confirmed the diagnosis?
Yes, sir. X-rays has confirmed the diagnosis.
So, do you need any other investigations?
I would like to do the MRI also.
Why?
To see if there is any additional lesion or the.
Did you see any Anderson lesion on the X-ray?
There is a lesion at L1, between L1 L2. There's a sclerosis at the disc margin, and there's an opening of the disc at that place.
That's at 2-3 also.
Yes, sir.
And you just said that you confirmed the diagnosis. Then why do you need any more investigations?
To further see if there is any occurrence of additional lesion is present in this.
So every patient who comes with every patient of Angstrom who comes to you, you will get a MRI done to rule out Anderson's lesion.
No, sir. If in history is complaining of any sharp increase in pain over a period of time.
So the answer to the Samir sir's question is that I would like further investigations because X-ray is confirming ankylosing spondylitis, but it cannot explain why the patient has sudden increase in pain.
Yes, sir.
Okay. Then you would also want to do the inflammatory markers, no, before that, because one of your thoughts was that it's an increase in the.
Yes, sir.
Okay. So you need to mention that inflammatory markers. Okay. Go ahead. MRI. Yeah. Tell me, what is the MRI showing?
These are the sagittal sections. There's a hyperintense signal at the L1, L2 disc and L2, L3 disc. And there's an opening of the disc at the L1, L2 level.
Okay. So is it an Anderson lesion?
For Anderson lesion, it has to be a 3-column lesion.
So is there anything posteriorly?
Posteriorly, I cannot make out.
What is that black thing over there just above? That disc, because I don't have a pointer here. So above that disc, go to the. So what would be a better investigation to see whether it's an Anderson or not?
Stir sequence.
Okay, stir is one. Then?
Gadolinium enhanced T1 sequence.
Are bapre. You're going on increasing. What would be a better investigation?
Why MRI? Alok. Does the patient have
CT scan?
CT scan would be, na? You have a CT?
No, sir, I don't have CT. Sorry, sir.
Okay. So a CT is very good because the CT will show you the full 3 columns, whether they're involved or not. Because what happens is this Anderson lesion, which involves the 3 columns, you can see anteriorly, you can see that little resorption around the edges, and you can see it. You can see the so-called fracture line going posteriorly through the facets and then posteriorly into the posterior elements. So that is very good. The other thing which sometimes helps is if you take a dorsal spine X-ray, you make him lie down and let him lie down for some time. Then you take an X-ray, then make him get up, let him get up for some time and then take an X-ray. So you can see there's a change in the deformity. So that also gives you a diagnosis of Anderson lesion. So this Anderson lesion word is a little distinct. There is so I have gone into like further depth of it to find out what the issue is, because there are, actually speaking, in the literature, there's a little confusion. In the rheumatology literature, Anderson lesion means something else. And in the orthopedic literature, it means something else. So in the rheumatology literature, an Anderson lesion is a medical Anderson lesion, which is an active spondylodiscitis. And an active spondylodiscitis is part of exacerbation of ankylosing spondylitis. That patient, if you do a CT scan, the posterior elements will be intact and they'll just be like a spondylodiscitis. And there may be a florid spondylodiscitis, including, increase in marrow signal on the stir images, etc. And the treatment of that is not surgery. The treatment of that is anti-inflammatory, and they use the TNF alpha. So they use Infliximab is the best, but they use some of the other newer ones now, right? So that is the medical Anderson lesion which the rheumatologists treat, which cause an acute exacerbation in pain. What we treat is the surgical Anderson lesion, which is like a 3-column pseudo fracture, and that requires surgery. So there'll always be a tussle, because what happens is that the rheumatologists try to give these patients also TNF alphas, and these patients obviously don't get better, right? So what is the principle? Why do you get an Anderson lesion, our Anderson lesion?
Due to abnormal stresses.
Because of?
And there is a high inflammatory activity at some point, and abnormal stresses around that point, there occurs a fracture.
So there's a fracture. So then why does it go into an Anderson lesion? Fractures can heal, no?
As the spine is in an attitude of flexion, so there is a constant force around that fracture. It doesn't let it heal.
So that is good. That is one part, that mechanically. But what other? I'm looking for one more thing. Looking for one more word, which is very important in this whole case.
Continuous inflammatory activity around it.
No, long lever arm.
Long lever arm.
So yes. Basically, all the spines are fused. So once it fractures at one point, there are long lever arms on either side. So that force concentration is very high. So that doesn't allow it to heal. And it wants to go into that kyphosis because of the way the thing is. And therefore, the posterior elements open out. And that's how you get it. Anyway, next. Achha, you don't have a CT, okay? Now, what are you going to do for this patient?
Sir, I have study images.
Yeah.
Because a lot of what you're going to do for this patient is based on what this patient has come for. So what does this patient come for? If he has come for pain, and I think without a CT is very difficult to go ahead. But if he has come for only pain, and this is a medical Anderson lesion, which it may well be, then all you have to do is refer him to a rheumatologist for these TNF alpha drugs.
Sir, one question.
If he has come for deformity, yeah.
No, sir, sorry.
Yeah, Priyank, ask.
So, Alok, why can't this be TB or any other infection?
There is, as per in the history, there was no history of fever, no history of constitution symptoms, no history of weight loss.
Okay, that's one point. Second. So you should always give all these 3-4 points on history, on examination, on lab investigation, on radiology. So what do you feel on radiology?
Radiology, the signal is high in the star image also.
So even in TB, it will be high.
Yes, it will be high.
Do you have any paraspinal swellings?
But there is no, yes, there are no paraspinal swelling or collection.
Correct. So that thing is missing over here. That is the differentiating mark. There is no soft tissue. Yeah. Can there be soft tissue?
Yes, sir.
Sir, your voice got disconnected. You can come again?
No. Can there be soft tissue?
No, sir. There is no soft tissue here.
So one of the differential diagnoses of medical Anderson's lesion or an MRI like this is spondylodiscitis infective. But with the history, the lab investigations, lack of soft tissue, it points more towards an Anderson's lesion rather than infective spondylodiscitis. But if you have a 3-column lesion with instability, cord compression, if you look at the actual sections, you could be, you can still get, it can still be misdiagnosed at TB. And so many times you have patients who are already started on anti-TB medicines when they present to you.
Yes, sir.
That you should know that answer to the differential.
Plus, again, I say that a CT is very important. Like, I mean, if this patient came to me as a patient, then I wouldn't proceed doing anything unless I get a CT.
Absolutely.
Because CT will tell you erosion versus sclerosis. It will show you the gaps. And what happens is all these, the fracture lines, they will have a sclerotic edges because it's actually a fracture going into a non-union. What an Anderson, what is an Anderson lesion? An Anderson lesion is a hypertrophic non-union. The same way as you can get an hypertrophic non-union of the humerus. So that is what happens. The edges get sclerosed. There is a fibrous soft tissue which forms in between. And sort of there is an expansion also as well. So it's a hypertrophic non-union, right? So this hypertrophic non-union can actually cause myelopathy. Okay, go ahead. So now what is your aim of treating this patient? Like what is it that you want to do for this patient or what does this patient want from you?
Sir, the patient has actually come for the deformity. So I will...
Because you can't, because this patient has come for pain, then you, or for instance, suppose this patient has come to you for stiffness. Suppose the patient has come to you for stiffness, you can't correct his deformity.
Then I will give anti-inflammatory only and newer drugs like TNF alpha blockers. But now this has come for the deformity. I would first like to get the proper X-ray done with the knee in the extension and patient standing against the wall.
Don't go there. Don't go there where TNF alpha and all. If you're thorough with all the knowledge, then it's okay. right now the question to you is, what would you want to do? You have an X-ray with you, you have an MRI with you, you have a thorough history, and suppose you have an CT scan. Now, answer to the point.
If on CT scan it comes out to be Anderson lesion, then we should then I will fix this lesion.
But you told patient has come for deformity.
No, you're right, Alok. You're on the right track, but you have to better justify your answer.
There can be correction of the deformity can also be achieved through the opening of this Anderson lesion while stabilization. And
that brings us to that X-ray which I told you about. X-ray, the sitting versus the this thing X-ray. Okay, so that is just for your knowledge. Okay.
And if on the proper X-ray taken, the deformity is coming out to be high, correction needed is very high, and I would like to do the proper deformity correction also with the pedicle subsection osteotomy.
Okay, so what are the two things which you will check before doing your deformity correction? Like,
first, if this is
my other question is that usually these patients, so this guy's got like a bit of a less of a deformity, right? Honestly, because nowadays we operate on a lot of things, we'll operate maybe this guy, but otherwise, no, I would not operate this guy for deformity. I will tell him that he's okay, he's walking, he's got ankylosing spondylitis, and with his by his knees and this, he's quite okay. He doesn't have a very serious deformity. So why are traditionally patients with ankylosing spondylitis deformity are operated? Like, what are they operated for? Like why do you operate on early onset scoliosis? Why do you operate on early onset scoliosis?
The deformity is progressive,
and they have a lot of growth left, so they will land up with all sorts of complications like pulmonary, etc., severe deformity. Why do you operate on an adolescent idiopathic scoliosis? Why would you operate on a 55-degree curve in a 17-year-old girl?
So all are progressing. All can progress and lead to severe.
No. Why would you operate on a 55-degree curve in a 17-year-old girl? 17 saal.
Because that curve will progress at 1 degree per year.
1 degree per year is nothing. It is up to 1 degree per year. So anyway, we don't want to get into scoliosis too much, but the answer is that it is cosmetic. The surgery for an AIS, adolescent idiopathic scoliosis, is often only cosmetic. It's no other reason, right? So now my question is, why would you want to operate on an ankylosing spondylitis patient? That's my question. Why do they usually come for surgery?
First is cosmetic also, and
no, first is not cosmetic.
Improvement.
They are anyway looking. They are looking so funny. Exactly.
Improvement of chin bro vertical vertex angle.
But how improvement of chin bro? They have not measured it. Even you have not measured it.
So what is
what they come for? That doctor, this is my problem. What is the problem? You're on the right track, but you just need to come with the right answer.
That word. Gaze.
You're not able to look. He's not able to look forward when he's walking.
They want to get the horizontal gaze.
Gaze. So you can also give prismatic glasses for that, by the way. It's a much cheaper way of correcting the gaze. Anyway, because we'll be running out of time. So two things you have to check for that. One of the things is the mobility of the neck. You have to see the mobility of the neck, and you have to see the problem with the hips, right? So why mobility of the neck? Because if suppose his neck is fixed in one particular position and you correct his deformity too much, then he will not be able to look at the floor only. You understand? He will only be able to look up. That is even worse than not being able to look up. He will not be able to look down after that. So that's very important for you, that if the patient, so these patients have a particular angle of gaze, right? So that angle of gaze, you are changing that angle of gaze. So you need to make sure that angle of gaze is in the useful range rather than going too high. So that is one. Why you need to look at the hips. If a patient has, so this is, I'll tell you, I don't want to spend 15 minutes trying to get it out of you. If a patient has got a lumbar kyphotic, a kyphotic ankylosing spondylitis deformity, but he also has hip flexion deformities along with protrusio and an added bonus of hip pain, then that patient is better off having total hip replacements rather than having an osteotomy of the spine. Right? Total hip replacement rather than osteotomy of the spine. In fact, there was a time when there was an argument that patients who have painless but flexion deformity of the hips, they do bilateral Salter's osteotomy to correct the whole alignment rather than do spinal osteotomy. But now spinal osteotomy has improved. So I think if the patient has painless hips, painless mobile hip, but not flexion deformity and has a kyphotic spine, then we select the correction of kyphosis. Okay. So now tell me a little about the history of correction of kyphosis. What are the osteotomies?
Sir, we can do the Smith-Peterson osteotomy.
What is that?
In that we remove the both the superior articular process as well as the inferior articular process. We remove the part of the lamina, ligamentous flavum, and then go
That
anteriorly.
is the procedure. I didn't ask you the procedure. I asked you what is the principle.
It gives a correction of around 10 to 15 degree.
What is the principle of the procedure? Smith-Peterson osteotomy, right? Smith-Peterson osteotomy. What is the principle of the Smith-Peterson osteotomy?
Sir, open wedge osteotomy.
Exactly. It's an anterior open wedge osteotomy. That is your Smith-Peterson. What is the other next osteotomy after that?
Pedicle subsection osteotomy, PSO.
And what is that? What sort of osteotomy is that?
It's a three column.
अरे अभी तो बोला open wedge osteotomy.
Closing wedge osteotomy.
Closed wedge osteotomy. So what was the problem with the open wedge osteotomy?
They're highly unstable and there are more chances of pseudoarthrosis.
No. What was the problem with anterior opening?
Injury to the vessels can occur.
Exactly. A rupture of the aorta. Other than that, there was no problem with the Smith-Peterson osteotomy. Okay? And then came the closed wedge osteotomy. So there is another. Okay. So how do you fashion the osteotomy of a SPO, which is a Smith-Peterson osteotomy, versus a PSO, which is a pedicle subtraction osteotomy? How do you fashion the osteotomy? Or other way, where is the apex of the osteotomy?
Apex of the osteotomy should be as low as possible. The lumbar spine.
No, that is the location of the osteotomy. That is a different story altogether. That will get with that's the next question. Where is the apex? An osteotomy is like this, na? So where is the apex?
The vertebral anterior part of the vertebral body.
At the
anterior column.
Yeah. Okay. So I'll tell you because like I said, it's late and whatever. So the apex of the osteotomy in a Smith-Peterson osteotomy, SPO, is at the PLL, posterior longitudinal ligament. Whereas in the pedicle subtraction osteotomy, it is at the ALL, anterior longitudinal ligament. So what happens is in a Smith-Peterson osteotomy, the apex is at the PLL and then you crack it open. So anteriorly it fractures through and it opens out. In a Smith-Peterson osteotomy, you don't take the osteotomy through and through. You just fashion it. You just remove the posterior elements and have the apex at the ALL and then you just fracture it through. So you literally fracture it. And I'll just tell you how the original was done in 2 minutes. Whereas in a pedicle subtraction osteotomy, the osteotomy is fashioned with the apex at the ALL, that's the anterior longitudinal ligament, so that the wedge is removed and then the whole wedge is closed. So that is why in that it opens and this it closes. So just to give you, because it's like a piece of history, the Smith-Peterson osteotomy was done under local anesthesia because it was not possible to anesthetize these patients in those days because they had these huge immobile necks and flexion deformities and chests. So they didn't give them general anesthesia. So it was done by Smith-Peterson by local anesthesia. The second thing, it was done in the lateral position because they could not place these patients prone because they were not even given anesthesia. So he used to do it in the lateral position by infiltrating local anesthesia constantly. And then after the osteotomy doesn't take much time actually. You just have to remove, it's like doing a laminectomy and this thing. And he's to put his knee, like I can't show you because it's a video. He's to put his knee and then just crack it open, crack it open. Okay. And after that, what fixation he used to use? No fixation.
No.
So this patients didn't require fixation because by gravity it got corrected. So when the patient walks, by gravity it is to get corrected. Then later on people modified, they used wires, some people use screws, etc. But then when anesthesia became safer, it was being done in the prone position. But otherwise, this is how the original Smith-Peterson osteotomy was being done. He had 2 cases of patients dying on table because of aortic rupture, and then that procedure went into distribute. Right? Then came this Leong, started this pedicle subtraction, known as the Leong osteotomy, Leong of Hong Kong. He started this pedicle subtraction or the wedge at the ALL. Okay. Next knowledge point. What is the location of the osteotomy and why?
Mostly at the L3, L4 junction, it is done because the cord is already end at the L2 level. So this osteotomy is done below the conus so that the minimum injury, if occurs, there is minimum injury.
So
and there is as you go down and do the osteotomy as slow as possible, then there occurs more correction of the sagittal vertical axis.
Exactly. So therefore, what is different about this osteotomy in an ankylosing spondylitis patient as opposed to if this patient has a post-TB kyphosis or a congenital kyphosis regarding the location of the osteotomy?
Congenital kyphosis correction has to be done at the very apex.
At the apex. So wherever the apex is, if it was D3-4, then you do it there. And this, so why is this done there? So what is this? What type of osteotomy is this? So it is a compensatory osteotomy. It is not done at the apex of the deformity. In fact, in the lumbar spine, the spine is usually straight. The kyphosis is much higher. The lumbar spine is usually straight. It is not even kyphotic in most of these patients. But you do the osteotomy over there at the L2-3 or L3-4 level because you want a compensatory osteotomy. And you do it at a place which is neurologically safe, like where there is no cord and the canal is wider, right? Of course, the important issue is that the upper lever arm, the movement of that or the amount of correction is based on how far it is from the apex. Because if it is, like you said, the lower you go, the more correction. And you can also have a problem of overcorrection. By overcorrection means the gaze is overcorrected. Like I told you, the patient looks up, then he can't look down again. So that is important. Anyone else has questions? Because I'm only asking. And I'm actually only answering, not just asking.
Sir.
Bolo.
Yeah.
Any other questions?
Priyank, sir, any question? Yeah. Priyank, sir, you are muted.
No, I think we have covered them. We don't have any
other
further
thing
exercise or anything beyond this, right?
So
Images?
the thing is that so the other issue is that you have to one osteotomy gives you only X degrees of correction. So you may have to do, if there is too much of a deformity, you may have to do more than one osteotomy, right? And you fix it, and it's an overcorrection. It is like like the lumbar spine is usually straight. You actually make it into like a hyperlordotic spine to correct the side. So now you need to calculate this. And there is the low tech way and the high tech way of calculating it. The low tech way is using tracing paper. So you use tracing paper and you trace out the thing, and then you calculate the wedge, and based on the location, whether it's L2-3, L3-4, you see the location and you see how many degrees of correction is required to get the chin brow vertex angle corrected, provided the cervical spine is mobile, right? And otherwise there is the software which is available, like SurgiMap. So on SurgiMap software, you can do the same thing. There you can just simulate the osteotomies and see what are the corrections. But SurgiMap is a software, but you can even do it just with tracing paper, which is what we used to do, right? And then of course you fix it with pedicle screws. And so obviously this case won't have the X-rays, no? The post-op X-rays won't be there. I mean, it's not an operated case.
Alok, it's operated?
Yeah, it's operated, but I was
You're
asked
not-
not to put the X-ray.
Okay. Okay. So he's not put the X-ray, sir. Post-op.
Fine.
What was done for this guy? Deformity correction or Anderson's lesion?
Anderson lesion fixation.
Okay.
So the deformity wasn't corrected only. We don't know actually.
Deformity correction was achieved only through the correction of the Anderson lesion only.
Oh, okay. So it is 5, 4, 3, 2, 1. L1, 2. Yeah, it's fair enough. But a CT is a must. I'm sure they must have done a CT. You know, like would have been there. And this X-ray also is very important. This supine and sitting X-ray is very important.
Yes, sir.
Okay, we are like at 9:40 now, so
Yes,
I also
sir.
run out of energy.
Thank you, sir. Thank you so much for your very important input, sir. Because this is a tricky topic which a lot of guys may not have seen deformity corrections for Angspon, and suddenly that pops up into an exam, and then students get flustered. So it was a very methodical way of how to present, what points to capture, what to speak, which words to use, and that is what actually sir has given in history as well as in examination. And also sir gave a little bit of history about the treatment, how the osteotomy is evolved. Thank you, sir. Anybody has any questions?
Mouth opening was very important. Huh?
Yes,
Mouth opening was important. We shouldn't have missed that actually.
Yes, sir. Yes, sir.
Thank you.
Thank you, sir. Thank you for spending this 1.5 hours for us. Thank you, sir. Bye.
Okay, bye guys. Bye guys. I'll leave I know there's a lecture, but I'll leave now. Yeah.
Yes, sir. Yes, sir. Thank you,
Okay.
sir.
Bye. Bye.
Good night, sir.
Good night.
So I can start sharing the screen now. We are actually
Yes, sir.
out
Yes,
of
sir.
time,
Yes,
but
sir.
we'll quickly
So-
go through.
Yeah. So guys, we may overextend the time today. Those guys who want to continue can be here, and we'll finish this lecture. And because what I wanted, because these two topics for today are very important. Being in both these topics, people get flustered. Like last AIS case presentation again showed us that there are many ways we can improve our presentations. And again, Angspon deformity, because many of us may not have seen any Angspon deformity in our fellowship. So the very structured way of looking at it, and you can make it very easy for exam. So now Priyank sir is gonna, he's a consultant in VR Spine in Mumbai. He's attached to all the big names, HN, Lilavati, Hinduja, a very terrific and fantastic surgeon and a very good guide. He's my senior in the unit, and he'll talk about how to go about methodically for history taking and examination. So Priyank sir, over to you.
Yeah, thanks, Harshal. So basically, like what Harshal said, it's not just with the students; it's with everybody. Whenever a patient with a scoliosis comes in front of you, you tend to get confused because it's suddenly a big ghastly deformity, which is too visual, which comes in front of you, and you're not sure what is happening, what kind of scoliosis. And the thing is, this is not something that you always see. That's why you tend to get flustered. So here it's not that difficult, because if you know what to see and if you're very methodical, you can easily decipher and you can go ahead and come out with those important points which you need to which needs to come in your head, which helps plan the treatment. And it's exactly like how a examination should be for any other, for your exams. So this is not important just for you guys, but it's also important for all the orthopedic and spine surgeons. So that's where we are going to talk about how to methodically examine a patient with scoliosis. The thing is that before you go that, there are certain important basic terminologies that you need to know, so that then all of us are in the same page. So first thing is, what is scoliosis? Now, the typical definition is that it's a lateral curvature of the spine of more than 10 degrees, which is measured by Cobb's method in a standing radiograph. So whenever there's a scoliosis, we see it as either a S-shaped or a C-shaped deformity of the spine from either the front and back. But that's not it. There is also a three-dimensional component to this. So there is, of course, a coronal deformity. There is a sagittal deformity. The coronal deformity can either be a C or a S-shaped curve, whereas a sagittal part could be almost always a hypokyphosis, or in very rare condition, there is actually a true kyphosis. And mind you, here we are going to focus on AIS because that's mostly what every one of you are going to get. There is one additional component to this, and that is the rotational component. And that rotational component is responsible for the bad looking rib humps, for the shoulder deformities, and for the unequal pelvis. So where you see one side, you have a prominence of the loin. So that is basically what the rotational deformity causes. Now, typically, whenever there's a rotational deformity, what happens is that the vertebrae rotates against a central axis and the body rotates towards the convex side, and the ribs go towards the opposite side, and that's why you see a more prominent rib hump. So that's the rotational part of the scoliosis. Typically, a scoliosis will always start with a single curve, which will keep increasing, and either it will decompensate or it will become well balanced with multiple compensatory curve. What I mean by this, you'll come to know as we progress. So whenever you talk about curve, there are two parts. There's something called as a structural curve and there is something called as a non-structural curve. Structural curve is basically where there is a fixed curve with intrinsic changes in the vertebrae. That means there is problems with the vertebrae. You can see either penciling, you can see rotational deformity, you can see asymmetry of the pedicles. So basically there is a structural element to that curve. One other way to determine if the curve is structural or non-structural is by looking at the bending X-ray. So if the bending X-ray bends symmetrically on both sides, that means that curve is a non-structural curve. But if a bending X-ray corrects a little bit on one side, but on the other side, it's asymmetrically bending. So maybe a curve which on one side goes up to 40 degrees, but on the other side goes up to 70 degrees, that is a structural curve. A non-structural curve is basically a mobile or a correctable curve which has no intrinsic changes in the body. So you will not see that the vertebrae are asymmetric, there's problem with the pedicles, you know, all the things that go on with a structural curve. And when you look at the bending X-ray, the spine will bend symmetrically on both sides when you're looking at the lateral bending X-rays. So that's the difference between a structural and a non-structural curve. The next terminology that you need to know is what is major and minor curve. So major curve is defined as the larger curve amongst the lot, and the minor curve is the smaller curve. Now both major and minor curve can be commented upon on a standing AP X-ray of the spine. Most of the X-rays that we talk about in scoliosis are standing X-rays. So you don't have to mention that, but you need to know that all X-rays that we are doing are standing. Now, whenever you have a scoliotic spine, there are three curves which are there. Okay. Because you have the upper, middle, and lower curve. It could be, all three could be structural. It could be one structural and two compensatory. But there are, whenever you look at the scoliosis, you have to look at all the three curves and determine which is structural and which is non-structural. Now, depending upon the type of scoliosis, you could have something called as double major. You could have something called as triple curve. A double major curve is where you have two curves which balance itself. So you have one C and the other C looking at the other side, so that it forms a S and both the curves start balancing itself. You could have something called as a compensatory curve. So compensatory curve is basically a curve which is above or below a major curve, which is formed by the body to balance the structural curve. So the compensatory curve could be structural or non-structural. So you have a major curve, you have a minor curve, you have structural curve, you have non-structural curve, you have got compensatory curves. So these terminologies you need to know so that when you actually start talking about the X-rays, when you talk about discussion, then you are on the same page. So if you look here, you have one curve in the mid-thoracic spine. Here you have one curve in the thoracic spine and you have a separate curve in the lumbar spine, and both is balancing itself. Here you have got three curves. You have got one curve in the mid-thoracic spine. You have a compensatory curve above and below it. Now, are these compensatory curves structural or non-structural? You can't comment based on this. You need to see the bending X-rays to see if it is symmetrically bending on the other side or asymmetrically bending. And here you can see that you have a double major curve, which is very well balancing the spine. So this is basically what different types of curves are. Now, if you go further in detail, you could have fractional curves. What fractional curve means? You see, sometimes what happens is the curve is supposed to be like this, but it ends here, and this is where the pelvis is. So if you actually end up visualizing, you realize that the curve should be like a C, but it abruptly ends, and that's where the pelvis comes. So that's called as a fractional curve. Then you talk about compensation, decompensation. So a decompensated curve or a decompensated spine is where the scoliosis is such that the curve is causing deviation of the body towards one side, so that there is a truncal imbalance, and that's called as a decompensated curve. And hence you can have a patient with ghastly looking scoliosis but a compensated spine, which means the head is balanced over the pelvis. Or you could have a smaller degree of curve, but the patient could be falling off on other side, and that is called as a decompensated spine. So here you can see girls with compensated spine on either sides, and the central girl is the one which is decompensated. The next that comes in terminology is strategic vertebrae. Okay. Now, strategic vertebrae are based, you hear these terms like neutral vertebrae, end vertebrae, stable zone, stable vertebrae, atypical vertebrae. What really strategic vertebrae are? See, they are basically the vertebrae that make the deformity. They are the vertebrae that can be used when you are planning your surgery to correct the curve. And those are the vertebrae that really matter to the surgeon so as to give a good surgical result. So the most important vertebrae are the end vertebrae, the apical vertebrae, the stable vertebra, and the neutral vertebra. So you have your full cricket team, but there are few strategic players who are needed in order to plan how you're going to go ahead. So that's basically how. So let's start with different vertebrae which are described. The end vertebrae. Now, end vertebra is basically the vertebrae which is maximally tilted on in the curve on either side of the curve. What it means is that if you see a curve and you start looking from the apex towards the end, the vertebra which is maximally tilted in the curve is the end vertebra. Now, how do you really identify that on an X-ray? You have to identify the curve, you have to look at either end, and you see the disc space. Now, what happens, just a second, I'm trying to get my pointers out. Yeah, so can you see this? Can you see my screen, Harshal?
We're able to see, sir. Yeah.
No, because okay, let me see if I can. No, I'll have to go.
So you just share your screen. Yeah. Don't
No,
make
that's
it full
it.
screen.
I'll do it this way because I need to explain this.
Yeah.
Okay. So you can see my pointer also.
Yeah.
The mouse pointer.
Yes.
Okay,
Yes.
So see, now this is the curve. Okay. What you have to look at is you have to look at the body and you have to look at the disc space. Now, if you look towards the concave side of the curve, you will notice that the space between the discs on the concave side is lesser than the convex side. And as you keep going away, you will notice that at one stage, the disc starts becoming parallel. And then beyond that, you will see that the disc is opening up on the concave side and closing on the other side. So you start identifying the concave side of the curve and you look at the disc space. At one stage, you see that it's becoming parallel, means this and this is equal. And beyond this, it is opening up. So this becomes the end vertebra over here. Same thing if you start going over there, and this is where you start seeing this is less, this is more, but here it is getting parallel and here it's opening up. So that's the end vertebra over there. So this is how you are able to identify what your end vertebra is. Okay. So basically, end vertebra is something that is maximally tilted vertebra on the either side of the curve. Now, each curve has got two end vertebrae. Always remember that. Now, what happens is when you do a bending film. So a bending film for this curve is basically where you bend the patient on the convex side. And when you bend the patient on the convex side, what you notice is sometimes the end vertebra shifts, because in this situation, you will notice that here the disc space is not opening, but here it's opening up again. So the vertebrae which was looking as an end vertebrae on the standing film, on the convex bending film, you are seeing that the end vertebra is shifting. So that is possible. And these vertebrae are called as intermediate vertebra. And the segment between the intermediate vertebrae is called as the stiff segment. Okay. Eventually you'll come to know why all these things are important. So by now what you have heard what end vertebra means, how to calculate or how to identify the end vertebra of the curve, and how to identify the stiff segment and the intermediate vertebra. But now you remember that every scoliosis curve has got different aspects. So you have got one structural curve, but you have two different compensatory curves. So whenever you're looking at scoliosis, you have to look at all the three different curves, and you have to start identifying the end vertebrae for all the three different types of curves. Now, so this is something that I just explained to you. So that's what end vertebrae is. That's what intermediate vertebrae is, and what stiff segment is. Now what you need to do is identify the apical vertebra. So now the definition for apical vertebra is the vertebra which is maximally rotated vertebra in the center of the curve. So here what you need to do is you have to identify the curve, and then you have to identify the vertebra which is in the center of the curve. And the characteristic of this, it is the least tilted, it is the most deformed or the most rotated, and it is the farthest from the CSVL. So that's the characteristic of apical vertebra. Now, not necessary. Sometimes what you will find that one single vertebra is not at the apex. There is a disc space which is at the apex. So it is not necessary that the apex could be apical vertebra. It could also be an apical disc, but the criteria still remains the same. Then you have to know something, what is a neutral vertebra. So neutral vertebra is basically the vertebra which is neutrally rotated on either end of the curve. So you remember scoliosis is a three-dimensional deformity. So there is always that one vertebra towards the end of the curve which is not rotated, and that vertebra is called as neutral vertebra. Okay. Just keep remembering these terminologies, because you'll have to get used to remembering this and easily identifying on an X-ray when someone says, okay, just identify the neutral vertebra. So you should at that time know what a neutral vertebra is. To identify the neutral vertebra, you should learn how to identify rotation on a X-ray. And to identify rotation on an X-ray, you should look at the pedicle. And there is something called as a Nash and Moe grading. And this is the Nash and Moe grading for describing the rotation. And it's a theoretical bit, but basically what you have to see is you have to see the spinous process and you have to see the pedicles. And what you do is you develop zones. So you divide between the spinous process and the end of the vertebra, three different zones, and see where you are seeing the pedicle. So here there is neutral rotation, but here what if you see what is happening, that this is moving towards the spinous process, this is moving away from the spinous process, and so on. And that accordingly is called as different grades of rotation. That was a theoretical thing which you need to know. Then you should know something called as stable zone. Okay. Now, stable zone is basically the zone between two vertical perpendicular lines from the base of the lumbar sacro joint. So where you have the lumbosacral joints on either side, if you draw a vertical perpendicular line, then if that both the lines are drawn from bottom to top, you have a zone, and the vertebrae which fall between that, this is called as the stable zone. Again, the practical why it is needed, you'll come to know with time. Then you should know what stable vertebra is. Okay. Now, stable vertebra is basically the vertebra which is most closely bisected by the central sacral line. So if you take the sacrum, you take the midpoint of the sacrum and draw perpendicular up at a particular step within the stable zone, you will have vertebrae which are divided by that line. The vertebra which is maximally bisected is called as the stable vertebra. Okay. The concept is that you should always end the fusion in a stable zone. Otherwise, you will have decompensation. This is a broad rule. There are some rule breakers, but this is a broad rule that you need to fuse from stable zone to stable zone. Like you have to, all the fusion vertebra should be in your stable zone. Now, the lowermost instrumented vertebra, when you are selecting the levels of fusion, should be the lowest amongst the three between the neutral, stable, and end vertebra. So see, when people talk like this, sometimes you get confused at what is the doctor trying to say. So you should keep repeating what a neutral vertebra is, what a neutral vertebra is, what a stable vertebra is, what a end vertebra is. Sometimes a neutral vertebra and the stable vertebra can be the same. So there are different criteria for naming them. But the broad dictum is whenever you're selecting your last instrumented vertebra, it has to be the lowermost amongst these three, the neutral, stable, or end vertebra. Okay. Now, basically, so you should always know your strategic vertebra whenever you're talking about scoliosis in any aspect. And these are the end vertebrae, the intermediate vertebra, the apical vertebra, the stable vertebra, and the neutral vertebra. We don't have a lot of time. Otherwise, I would have pulled you guys up and asked you to revise. But I think we are going to do that the next time. So if you're sleeping, then be awake, because this is something that you'll have to revise before you start the next talk. The next time you're going to have radiology, right?
Yes, sir.
Yeah, and that's the time we are going to directly ask you, okay, point out which is the end vertebra, which is the stable vertebra, which is the apical vertebra over here. So remember these things. With all these basic terminology in mind, you can start with the AIS history taking. Now, again, since we are doing case presentation after case presentation, what we are going to focus on is the important point on the history, important point on the examination, so that you can next time move on to imaging and the treatment methodologies. So in history, the specific thing that you want to know is the age. You want to know the age of the patient, because the younger the age of the patient, it is more likely to progress. Then you have to find out these specific things about growth spurt. You have to ask questions about puberty, the menarche, because that will help you plan the treatment ahead. You should know the birth history of the patient. Did the child have any birth anomalies, any surgeries at the when the child was young? So then that can tell you if the patient is AIS or if it's a congenital curve. You should also know about the sibling history, so that because congenital scoliosis are seen in families, whereas AIS is something that does not have any history. But you should know about it. And then if they have siblings, they should also be screened. Then you should find out when was the curve first noticed by the patient, so that you can differentiate between early onset, late onset. Then the history should be about the progression of the curve. So you want to know, is it gradually progressing? Is it suddenly increased? Was the child completely normal till 10 years of age, and at 12 years, suddenly the patient is coming with a hip back? So that will give you an idea about when the curve has presented and how fast is the progression of the curve. Remember, whenever a patient is talking about a sudden rapid progression in a younger age group, then you have to be careful. You have to be aware, because then you're looking at a congenital scoli or neurofibromatosis or something, and it's not mostly AIS. The next part that you want to know from the parents or in the history is what is the complaints. It is very, very, very important, this question, because you have to understand that a patient with AIS will have no complaints other than deformity. If a patient, so they can have mechanical back pain, but mechanical back pain and a significant back pain is different. So any scoliosis patient complaining of back pain, leg pain, weakness, some dysfunction and breathlessness, it is a red flag, and you have to be aware that this might not be AIS. This might be something else. So the next part that you want to ask is, what part of the deformity concerns the patient the most? Is it the shoulder? Is it the limb hump? Is it the limb? Is it the leg deformity that the patient has, or the hip or breast, head, neck? All of this is important, because your entire planning, decision making is going to depend upon what is the patient's expectation. Mind you, we are talking about AIS, so all these cosmetic questions have a lot of significance. You want to also rule out if there is any other system involvement. So you have to just briefly screen regarding the kidneys, the hearts, because then you see this in a lot of congenital scoliosis where there are multiple different systems that are involved. What do you see when the patient comes? So once you have your history set, you look at the patient in a particular way. The patient has to be examined in the standing position with the patient uncovered right from the nape of the neck to the buttock. Preferably, see, a lot of these AIS kids are females, so they are uncomfortable. So it's better that you ask the mother to be around, or sometimes if the patients are not comfortable, you can step out of the room. The patient can undress and take a picture in a standing position. You can see the mobile and they'll be more comfortable. But the idea is that the patient should be comfortably standing without any hand supports, with the hand dangling by the side, with the spine exposed right from the nape to the buttocks. Here, what you need to see is you have to look at the neck to see if there is any tilting in the neck. You should see if there is any fullness of the shoulder. So is one side trapezius more prominent than the other side? You want to see the shoulder. You want to see if one shoulder is above the other shoulder. You want to see if there is any chest deformity. So you see if there is any rib hump, or if a patient has complaint of chest asymmetry. So you see if there is breast asymmetry. Look at the arm trunk distance. So basically what you need to look at is the distance between the arm and the trunk. You will always see it is more on one side than the other side. You want to see if there is shift of the trunk. So draw an imaginary line from the gluteal cleft and see if the entire trunk is shifted towards one side. You want to see if there is any rotation in the flank. So you want to see if there is one side flank crease is more prominent than the other side. You want to see if there is any pelvic tilt, to try to see the dimple, see the PSIS, and see if they are in one line or one is lower down than the other. You want to get a brief idea about what is the limb attitude. So see if the limbs are straight, if one knee is flexed and the other is not, to get a brief idea if the patient has got any limb length discrepancy. And generally see if there is any, when the patient is walking, if there is any limp, or you want to see if one calf is wasted than the other calf, and the detailed neurological examination, which I'm not going to talk about here. So here, we just spoke about all these things. What all you have to measure from the top to bottom. You have to see the head level, shoulder tilt, chest deformity, rib hump, flank crease, pelvic tilt, limb length discrepancies, and if any neurological problem. A rib hump can be better seen in a forward bending position, and it's also called as the Adams forward bending test. And to measure the rib hump, there is a device called a scoliometer, which you have to keep when the patient is maximally bending forward along the rib, and you have to measure the angle. So that's one other way. There is also a historical way called as a 2 textbook method, where you have to keep 2 textbook and then align that and see what is the angle between the two. After this, you want to examine the curve. So what you want to see is, you want to see the range of motion of the spine. You want to see by flexing and extending the spine, you want to see the bending, so lateral bending. You want to know if the curve is flexible or rigid, and that is done by something called as a suspension test, where you can have someone hold the patient from the chin and lift the patient till at least both the heels are off the ground, and you don't do this, you ask someone else to do it. So from the back, you can see if the curve is opening up. Then you want to see what happens to the patient when they're sitting down. What is happening to the pelvis when they're sitting down. Sometimes if it's pelvic obliquity because of limb length discrepancy, on sitting down it will straighten up, versus it might not if it is a fixed pelvic instability. You want to observe the patient when they're walking, if there is a short stepping gait or a high stepping gait. So all these things you want to observe when so these are part of examination of the curve. And you have to end by examining the spine and neurology. You should also examine the secondary sexual characters, so that you can then predict how much growth is remaining. So you want to see if for the pubertal signs, you want to measure the height of the patient. You want to get details about, and with this, you will be able to find out how much growth spurt is remaining. The next part is you have to determine if the curve is going to progress or not. Just general thumb rules are that when the patient is young with risers 0 to 2 in a female child, sorry, just 1 second. So we are going to talk about this in some time. about what a riser scale is and everything. But basically, the thumb rule for scoliosis progression is in a young patient with riser 0 to 2, female, family history, Cobb's angle more than 20 degrees, significant rotation, double major curve, rib vertebral angle, RABD of more than 20 degrees. So there are so many different criteria for curve progression, which you can find out on an X-rays. So by now, what you need to know is about the history and what you see in the history and the examination. Post this, of course, you're going to be asked to ask what to do next. So Harshal, do I cover the radiology part now, or is it going to be a part of your next talk?
So we'll cover radiology later. I think what you have told is very relevant because there's a vast history. We'll just stop today, sir, right? I'll just brief it for everyone.
Unless what I could do is, so next time, is it going to be X-rays and students telling about it, or are you going to show how to measure the Cobb's angle, how to do the end vertebra and everything?
So it is going to be a brief about radiology and then planning immediately after that.
So then how to identify the end vertebra, how to calculate the Cobb's. So then this part I won't cover now because that becomes too much. Okay, so I'm going to stop sharing the screen now. I want all the other guys, if you have any questions regarding what we just spoke, you can put it up now, or then we'll end it this time, and next time we are going to continue with the scoliosis bit. And at that time, we can again revise between this important terminologies like end vertebra, intermediate vertebra, stiff segment, stable zone, stable vertebra, neutral vertebra, what is CSVL, all of these part will continue in the radiology of scoliosis.
Yeah. So anyone has any questions, so can ask. Fine. So I'm gonna just brief it for you guys that this talk was actually consolidated with regards to constraint in the time, and sir has come to very specific, clinically relevant points. What happens that all the points which sir talked about is basically where your either treatment is going to dependent on it, or it's going to be an exam oriented point for you. Apart from that, next time also we'll give a, I'm going to share on the group also, that exam spine boost group, the model case where proper history is being taken, proper negative history is being taken, and there are some important findings. So we'll end it for today, and a model case will be posted on the group so that you guys will have a proper history and examination for AIS case, right? And thank you, sir. Thank you so much, Priyank sir, for spending 2 hours with us, giving your valuable inputs for these cases. Angstpond is a very important case, a difficult case. You have to have a very good understanding of the deformity and everything. Don't talk about things which you don't know, like rheumatology, TNF alpha medicines and everything. Just come to basics, have a very specific understanding, and come to deformity, pain, and a good history, HOPI, and specific examination. Don't get flustered by deformities and everything. And same with AIS. AIS has to be a very methodical assessment, a good history, a good examination, and then present your case accordingly. These are not difficult things to assess in an exam. You can easily pass with these 2 cases because expectation from examiner also is very limited for you. Okay, but as spine fellows, you should know in and out about these things. So we'll end it today, and thank you, Priyank sir. Thank you all the guys.
Just one thing, Harshal, homework for all the boys. See, whenever you're getting an Angstpond case, you are going to be asked about the different types of osteotomies. Okay, so you go back and you have to read up on the types of osteotomies and what are the principles behind the osteotomies and how much correction you get with each osteotomy. So you need to know about Smith-Peterson's, so SPOs, PSOs, chevron osteotomies, then vertebral column resection. So because with Angstpond, you're going to go in all of those things. So you need to read up the history, the different classifications and the type of osteotomies, how to do them, what are the ideal locations, because at the end of the day, the ASSI exam is going to go till that level.
Yeah. So you are anyways going to go to management. And though Samir sir is not here, but I must take this opportunity to thank him. because he single-handedly gave you the entirety of the history-taking examination and all the relevant points. And I hope Samir sir is as cordial in exam as he was today for you guys. Thank you. And we'll end the session today. Thank you, guys. Bye. Good night.